Good morning, everybody. Welcome to this second day of this exciting conference. We're looking forward to another great day of interaction. I would like to thank the speakers for inviting me as a session chair in this first session of the day. My name is Heila Platz. I am an anesthesiologist based at Sefako Makgatho Health Sciences University and Dr. George Mukari Academic Hospital in Ga-Rankuwa near Pretoria in South Africa. So the first talk, none of the speakers in this session really needs much introduction, and I'm very pleased to ask Dr. Meseret Gebra to be our first speaker. She will be speaking on clinical research ethics. She is a pediatrician that's been working for more than 10 years as a clinician, a clinical researcher, and a trainer at Armauer Hansen Research Institute in Addis Ababa in Ethiopia. Speaking with her is Bruce Picard. As you know, he is a proponent of international collaborative research and has been leading the ASOS2 trial and the ACOS studies through the collaboration with the African Perioperative Research Group, or ACPOP network. So I'm very happy to introduce these two speakers to you to talk about clinical research ethics. Thank you.
Good morning. My name is Meseret. I am a pediatrician and a researcher working at AHRI. In this session, we are going to talk about clinical research ethics. So the outline of my presentation will be, we'll have a brief introduction. We'll see into the historical accounts of some important ethical breaches. We'll see the ethical requirements of clinical research, responsibilities of researchers and scientific misconduct, and we'll have a summary. So what is ethics? So ethics in the context of clinical research is about the norms, values, what's right, what's wrong, or what is good or bad, and what we ought or ought not to do in the context of clinical research. So these are a set of norms which we need to apply while doing any clinical research. So why do we need research ethics? So the main purpose of a research is to get a generalizable knowledge on a certain topic so as to improve the health of a society. So it's important, it adds value to the society. But in order to do that, we need to involve research participants. So while involving those research participants, it's important to respect their safety, dignity, and autonomy. That's why it's important to have ethical guidelines. So while we are trying to get some generalizable knowledge, we are approaching some few individuals to get involved in certain research, and they are asked to accept some burden or risk in order to benefit others and society. So while doing so, there are risks for potential exploitation or abuse of such human participants. That's why we need research ethics. So coming to some of the remarkable historical ethical breaches in the past, though there are quite a lot of them, there were two remarkable or influential ethical breaches, which has led to development of different research codes and guidelines. The first one is the Nazi experiments, which was done on prisoners of war, and which led to the Nuremberg trial and Nuremberg Code in 1946. The second one is the Tuskegee syphilis study. So the Nazi experiments included different experiments. Their intention was, one, to facilitate survival of their military personnel, As part of that, they did different ethics experiments, like high altitude experiments, treatment for hypothermia, and making seawater drinkable. So they did these different experiments on the prisoners without any consent or agreement by the participants. They also did different drug and treatment studies to treat different illnesses such as malaria, TB, and typhoid, which had affected their military. They also did sterilization of Jewish and Roman people. So these were very unethical research experiments done on prisoners. The second remarkable ethical breach was the Tuskegee syphilis study. This syphilis study was done in Tuskegee, Alabama between 1932 and 1972. So the objective of the study was to study the natural history of untreated latent syphilis. They involved more than 400 black men with syphilis, and there were around 200 without syphilis who served as controls. So during this study, there were a lot of ethical issues. One is the participants were not given adequate information, even they were misinformed, that they believed that they were getting free treatment. They were misinformed that the spinal taps were meant for therapy, but that was not the case. And this study just continued. And the participants were not offered treatment when penicillin was discovered in 1943. It was discovered as treatment for syphilis, and people were getting it, but these participants were not allowed to receive penicillin, and they just continued the research. So in 1972, press reports caused the US government to stop the study. So this was also another very important historical account of ethical breach. And as a consequence of such ethical misconducts, different ethical codes and guidelines were developed to list the main ones. Nuremberg Code, this was developed as a result of the Nuremberg trial of the German physicians who were involved in the Nazi experiments. The other is the Declaration of Helsinki by the World Medical Association. Other guidelines included the Belmont Report, SEOMS, and the US Common Rule. So, though there are different details in these guidelines and codes, they revolve around these three key ethical principles. So the first one, while we are thinking of any clinical research, we have to adhere to these key critical ethical principles. The first one is respect for persons. So individuals must be treated as autonomous agents, and those participants with diminished autonomy must be protected. Their rights must be protected. The other important ethical principle is beneficence and non-maleficence. This is about doing no harm, and also we have to maximize as much as possible the benefits and minimize possible harms or risks to participants. And the other key ethical principle is justice. So we have to be fair while selecting participants for a research. So all individuals must be treated fairly while carrying the burden of the research and also benefiting from the research. So coming back to these ethical principles, we apply these ethical principles as we apply a respect for, we show our respect for persons mainly through informed consent. So we have to respect their autonomy by getting a valid informed consent. Beneficence is assured through a critical risk-benefit analysis so that we can maximize the benefit and minimize the risk to the study participants. And justice. While selecting study participants, we have to be fair in the distribution of burden and also benefit from the research. So to see in more detail of the ethical requirements of clinical research, as you know, the main goal of ethical guidelines is to both to protect the study participants and also to preserve the integrity of science. So in order to assure that, there are different ethical requirements of clinical research. There are 7 ethical requirements. We'll see each of them in more detail. So the first one is value. For a clinical research to be ethical, it should have a social or scientific value. It has to have a goal to improve the health and well-being of a society or increase scientific knowledge. So the main reason why we need to have such social, scientific, or clinical value is to avoid exploitation of study participants. We need to protect study participants and avoid their exploitation. And also we have to be responsible while using the limited resources we have. So for such reasons, it's important to have value. The other is scientific validity. Always while doing any clinical research, we have to do it in a methodologically rigorous manner. And in order to have that methodological validity, we need to have a valid research design for the research question we are going to answer. And the research should be conducted carefully and accurately in accordance with the design we have proposed. So even though some people think that science is not related to ethics, but it is, poor science can be equated, or it's said to be equivalent with poor ethics, because if we have poor science, then participants will be exploited and exposed to unnecessary risks, and also we are going to waste the limited resources we have, which we could have used to other important research questions which could help the health of the society. So scientific validity is also very critical in terms of ethical clinical research. The other is fair selection of participants. So while thinking of selecting study participants, it's important to note that the scientific objectives or goals of the study must be the primary basis for the inclusion or the exclusion of participants. We shouldn't include participants just because they are easily accessible, or it's easier to enroll them, or it's easier to get consent from those participants. Our main base should be the scientific goal. And also exclusion should also be reasonable. We have to be reasonable while we are excluding participants. We should have adequate scientific reason to even exclude participants. So the other thing is participants also should be selected in a way that it minimizes the risk and also maximizes the benefit to the individuals and also to the society. So we have to be fair in selecting study participants. Always the burdens of the research and the benefits should be distributed fairly during participant selection. We shouldn't we shouldn't ask some participants to bear the burden of the research to benefit other participants who are not taking the burden of the research. The other key ethical requirement is favorable risk-benefit ratio. Whenever we are thinking of any clinical research, that research is ethically justified only if these conditions are met. The first one is potential risks to individual participants should be minimized, and the benefit should be maximized, and the potential benefit to individuals and society should be at least proportional or should outweigh the risk. So this risk-benefit analysis is in line with the principle, the ethical principle of beneficence and maleficence. So ensuring that the benefits outweigh the risk is important to avoid exploitation of the study participants. The other important ethical requirement is independent review. Always when we think of doing any clinical research, we all know that it needs to pass through an independent review by the Research Ethics Committee or the Institutional Review Board. So as we all know, as investigators or researchers, we may have some competing interests which can lead to conflicts. So we may need to complete a study in some limited period of time. Because of that, we may modify the methods to accommodate the time constraint or something like that. Or we may exclude some participants which would take more time to enroll or to get consent or something like that. So because of such different scenarios, it's likely that researchers or investigators will have a conflict of interest. Because of that, it's important to make any study or clinical study to be reviewed by independent reviewers who are not affiliated with the research. So normally we have to have IRB approval before we do any clinical research. This is one of the requirements. So the other important ethical requirement is the informed consent. So the informed consent has two main objectives. One, it will help us to ensure that individuals will have a control over whether to be enrolled or not enrolled in a particular research. And also it ensures that participants will participate only if the research is in line with their interest, values, or preferences. So in order to assure that, we need to get a valid informed consent. And always we have to make sure that the consent is, informed. The participants should be well informed about the research, about the risks, about the benefits, and all important aspects of the research, which would help them to decide whether to participate or not to participate. The other issue is respect for study participants. Of course, one of the way we show respect for participants is through informed consent, but that's not the only thing we have to do to show our respect. So respect to participants should be given from the time they are approached to participate in the study, throughout their participation, and also after completion of the research. So this respect includes, like, we have to protect the participants' confidentiality and privacy, and also we have to provide opportunity to withdraw at any time during the study without penalty. The other is, whenever we get any new information regarding the study, we have to provide that information to our participants, and sometimes we may have to also get another consent or reconsenting if it's necessary. The other is, we have to monitor the well-being of the participants throughout their participation in our clinical research. And also, even though it's not usually done, it's important to inform the participants the results of the study. It's also, in a way, recognizing their contribution to the research, and especially if it affects their health. It's important. Even the ethics committee strongly recommends researchers to communicate study results. The other is, we have to also compensate participants for any research injury which might arise during their participation. So these are the important ethical principles any investigator or researcher should adhere to while thinking of any clinical research. Now let's look at the responsibility of researchers. We'll have some slides on this, and also research misconduct briefly. So responsibility of researchers include proposal development, obtaining ethical approval, and this is important before starting any clinical research. And also we have to ensure protection of study participants. It's not only the responsibility of the ethics committees to ensure protection of study participants. As investigators or researchers, we are also responsible. And also we have to strictly adhere to ethical principles from national and also international guidelines. We have to adhere to study protocol and essential professional standards. And we have to also be able to generate credible data. So research integrity is one of the important things we need to have as a clinical researcher. So research integrity starts from the study design. So we have to have research integrity during designing our study, including our statistical assumptions, sample size determination, randomization, and during conduct of the study, conduct and recording of the study, we have to use appropriate standards, we have to use appropriate recording formats in order to keep the research integrity. During analysis and reporting also, it's very important to be honest in reporting results. We have to report even negative results with honesty. We shouldn't omit important results. And also we have to keep scientific validity by using appropriate analytical tools. It's also important to disseminate our research findings in peer-reviewed journals. So this is important. It's important for us to keep in mind that research integrity starts from the design up to the final analysis and reporting. So coming to scientific misconduct, I think it's important for us to know scientific misconduct as researchers. So it's defined as fabrication, falsification, or plagiarism in proposing, performing, or reviewing or reporting research results. So fabrication is just making up data or results and then recording and reporting them. But falsification is manipulating of different parts of the study, including it could be the research materials, equipments, processes, or any part of the data. And plagiarism is use of another person's ideas, processes, or results without appropriate credit to that individual. So there are consequences to serious consequences to scientific misconduct. This could include injury to patients and to health delivery. Depending on the type of misconduct, it would waste the limited research resources we have. It could lead to also questioning or doubting of all past work of the guilty researcher. So if as a researcher is found to be involved in a scientific misconduct, then all the research works which he or she has done in the past would fall under serious questioning. So in summary, as a clinical researcher, we are responsible to not only to advance the science, we are responsible to protect the research participants. So in order to protect the research participants, one of the most important thing is scientific validity. We have to use proper research methods and have proper analytic plan, and so on. So scientific validity is very important. The other is we have to obtain appropriate or valid informed consent from each research participant. Risk-benefit analysis is very important, it's very critical. While thinking of any clinical research, it's important to analyze this so that we can maximize the benefit and minimize the anticipated risk. The other is fair selection of participants is very important. It's important to be fair while distributing a burden of research and also benefit of research. And the other is it's important to conduct research with integrity, starting from the design up to the analysis and also reporting of the results, and also we have to comply with the recommendation by the research ethics committees. So
I think it's let's maybe carry on and hear Bruce's talk, Prof. Bicard's talk on clinical research ethics, and then take questions at the end of this first presentations.
Thanks, Ella. And thanks, Dr. Meseret. I think my talk fits very nicely after Dr. Meseret's talk. And really what I've done is I'm going to talk about our experiences with clinical research ethics, predominantly across Africa with some of the big collaborative projects we've done, and some thoughts on some of the challenges and solutions. So these are the funding, you saw them yesterday as well. So in summary, this is what I hope to discuss. First, the context in which we are trying to do clinical research at scale in Africa. And then a bit about the ethics and regulatory approvals, both the structure and function of ethics committees we've worked with in Africa. A bit about study design and the concerns ethics review boards have and some of the challenges. I'm going to suggest a few solutions which I think can help us with clinical research ethics in Africa. And then at the end, I've got two questions which I want to pose right at the end for all of us to consider. So if we look at the context of the researchers and the research environment, the researchers essentially in the work we're doing as a group are clinicians who are enthusiastic, but essentially are unfunded. The second part is the research environment that the majority of them have is extremely limited to non-existent. So they're very limited research support. And I think we just need to keep coming back to this figure. This is the reality for the majority of people who are doing research in Africa. They are clinician providers with limited research support, and they're working in a very demanding situation just because there's so few clinicians where they are. Despite this, we know that the clinicians in Africa are very keen to do important collaborative research, and this is obviously a strength of our network. So now what I'm going to do is I'm going to show you really what the ethics and regulatory approvals look like in Africa, and this is data from ASOS2, which was an interventional trial, and it's the data at registration from the national leads and hospital leads for the trial. So from 39 different African countries and 333 hospital leaders who registered an interest in ASOS2. So this is what it looks like. On average, there are about 4 ethics review boards per country. The constitution of the ethics committee is about 8 members. They meet probably about once every 1 to 3 months. And the fee structure for investigator initiated and led, and I think this is important, all the work we do is not industry funded, it's all research by clinicians. And the fee structure for that is unclear. So the first thing I want to show you is, in general, almost 60% across the board there's a very poor understanding of the ethics review boards in Africa. And I don't know if this is either as clinicians, we're unaware of the ethics review boards, or if the structure and frequency of events is very is not regular or scheduled. So 60% do not know that if they're independent people on their review board outside of the local institution. The frequency of the meetings is unknown in 2/3 of the cases, and whether fee is payable is also unknown in nearly 60%. And I think this is really important. So it's a very strong message here that we need to know more about the local ethics review boards. I think the second very important observation is that the review boards meet most commonly 1 to 3 monthly. I mean, if a review board is meeting every 3 months, to approve a big collaborative project can take a long time. And so this is certainly an area which also needs to be considered and addressed. The next thing is that at any site, there are a number of ethics and regulatory requirements that have to be achieved. And so if you look at these responses, about a quarter will need a national regulatory approval. About a half will then need a further regional regulatory approval. And then there will be another quarter who require local ethical approval, and over half will also require local regulatory approval. This is extremely demanding and a lot of replication of services. So I think, you know, if you want to look at the ethics process to get a big project running across Africa, it looks like something like this. So you do your primary ethics approval, where the protocol receives its first ethics approval. From that point, it then goes out to all the sites that are keen to participate and countries that are keen to participate. A quarter will require national approval, half will require a further regulatory approval, regional approval, another half will require a regulatory local approval, a quarter local ethics approval. And then there's still, unbelievably, another 10% which will require other approvals. This is extremely demanding, and I would suggest a lot of these processes are redundant and repetitive, and they are not good for ensuring safe, ethical clinical research in our environment. Also, another thing is that the local knowledge of the ethics review process is limited. And as I said earlier, it might be because the process is not clear or the clinicians are unaware of the process. But either way, only about 40% of clinician researchers understand the ethics review board process at their local site, but they have a very good understanding of the regulatory requirements, with over 80% being very clear on what's required. And if you look at the timelines, The review boards meet every 1 to 3 months, which means you do a submission, it's reviewed, comes back with queries, and then it's going to be another 1 to 3 months before the queries are responded to, then another 1 to 3 months with all the responses again from the ethics, and quickly this process takes a very long time. If you look at some of the challenges that we have had with the review boards. So the first is, if we look at the different study types, the observational studies, the concerns have always been about finger pointing and data privacy. So concern that a hospital where the outcomes might be very poor is identified. But, you know, on principle in the AppOrg network, we've always worked on the philosophy that we will always ensure that all sites and countries remain anonymous, because basically the signals we are looking for are generalizable, that we can address at a continental level. And so, you know, speaking to ethics boards about that, I think obviously is extremely important to them, and it's an understandable concern. But I would say it's not a real concern, because we ensure that that's not, our intention is never to expose sites to countries. In the interventional trials, so I think this has been extremely important learning in ASOS2. We had nearly 10% of the hospitals, we never achieved ethics approval, and hence they could not participate. The basic or most common concern was a lack of equipoise for the trial. And most of the ethics boards felt it was unethical not to provide the intervention of increased post-operative surveillance. We obviously had a lot of face-to-face meetings with these ethics boards, but we still could not achieve ethics approval at 10% of the hospitals. And I think this is extremely important discussion for a number of reasons. So for ethics, for research to be ethical, there has to be equipoise. In other words, we are not certain that intervention will provide improved outcomes. So in ASOS2, the equipoise lay in the fact that if we provide more attention to the sick patient, does that mean the low risk or not that sick patient will do worse? In other words, there's less time looking at that patient, and that's actually where the equipoise lies. And it's interesting at the end of ASOS2 now to know two things. Firstly, asking doing the clinical trial was important, because even though 10% of the ethics committees felt that it was unethical and we should just be doing it straight off, if we had done that, we wouldn't have known now that providing increased post-operative surveillance did not improve the outcomes for the patients. And in fact, we've learned where the ethics boards felt it would. What we've actually learned is that it's much more complicated, and there's a whole lot about implementation fidelity, which is extremely important if we want to improve outcomes. That's the first thing. And the second thing, we actually have learned from ASOS2 that providing care for the very sick patient didn't compromise the outcome of the low-risk patient. And that's a super important signal we've learned. And it means in the future, it is ethical to provide studies which are only looking at the high-risk patient, because we know the low-risk patient hasn't been compromised by that strategy. Another problem that we had or have had with ethics review boards is that when the primary ethics approval comes from another country, there's an assumption that lots of ethics boards make that the investigators are therefore well-funded. And there are these ridiculous ethics review board fees as a result. And as we all know, none of us are well-funded. And we've done a lot of this research with almost nothing. And certainly face-to-face meetings, again, with ethics board are super important for them to understand actually who we are, what we do, and what our vision is for improving care in Africa. How does one go about managing these mass ethics approvals? I showed you how much redundancy there is. In fact, how many times you dealing with ethics review boards just for one site. And if you consider if you got 300 sites, what it could be like. So the advice is firstly to have a frequently asked questions document. So a lot of very similar questions come up from review boards. So every time you get a new query from a review board and you prepare a response, keep that response as that question and response as a template, and you build up a very big document so that you can deal with the concerns that the ethics review boards have. I also would really advocate, meeting with review boards, having face-to-face meetings. This is a very productive way of understanding their concerns and ensuring they understand what you intend to do. And then we'll look at 2 questions, which I think could be part of the solution at the end. So I just want to go back to face-to-face meetings with ethics boards. I think this is the most important thing we can do as clinician researchers, is it helps us understand what they're worried about with the research. It's often hard to communicate that in an ethics review board response to the investigator. And it also helps us ensure they understand what we're trying to do. Often, I think a review board might not totally understand our intentions, and to be able to talk honestly is very helpful. And I think, as clinician researchers, we also got to realize that every time a decision is made, either ethical decision or a regulatory decision for research, it is potentially precedent setting, which means that will be how it will be at the next time we try and do a project. So this is it's incumbent upon us then to challenge ethics review boards where we believe the request is inappropriate. And so there are situations where the need to consent a patient in observational work might be inappropriate, and it might create bias in the study and the data collected. And we need to challenge that. We need to discuss it with the ethics board, and they need to understand that. And similarly, the exclusion of certain high-risk patients from studies certainly creates a lot of bias in the sample, and discussing that situation as well is extremely important. So you'll see, if you look at the work that AppOrg has done, we've had waivers of consent to allow us to keep data on patients who've died, for example, so that we don't have a biased sample which only looks at the healthy patients. We've had broadcasting as a form of informing the population that a trial is happening, for example, in ASHOS2, where there's signs in the hospital saying this hospital is part of a project or a trial, and you have the option of opting out, as opposed to the converse where you have to consent every patient to opt in. So I think these are really important, and it's really, we have to ensure that we work ethically, but the ethical demands on the research are reasonable and do not compromise the data because that's no service to society at all. If you look at, you know, where we're going, I think our vision for perioperative research in Africa is to develop this holistic research culture, and I think we certainly are moving that way and getting there. If you look at AppOrg, we've got people who've registered from over 42 countries now, 705 hospitals, and nearly 1,500 clinicians across the continent. And really what we have to do is provide a research infrastructure support for this group to ensure that, you know, we can all conduct research ethically, but also quickly. And so how do we do this? So if we go back to the AppOrg member database, so on that database, we want to have all the clinician investigators, which lists their research interests. And also we keep records of their GCP accreditations and provide information to let them know when they renew the data or need to renew their GCP. So for example, in ASOS2, getting the GCPs for the whole continent was like extremely difficult. It was a hell of a lot of work. But the reality is that has helped us now build like a big database of GCPs of clinician investigators across Africa. And now, you know, as a service to the investigators, we can provide reminders of when their GCP is about to expire so that they can do it timelessly, and it would be a lot easier. Similarly, on the database are all the studies with the documents needed to do the studies and to do ethics approvals, who the collaborators are, and all approvals, and then facility data. So in the studies, to understand the context of the data, or we do need to understand information about the facilities that each of us work in. And so if we keep a live database of all our facilities, you know, over time that we don't need the redundancy that every time we do a study, a hospital investigator needs to put that information in. It exists already. So I'm going to just show you quickly. So this is the African Perioperative Registry or network, which I encourage all of you to, if you haven't registered yet, to register on it. This is the QR code and what the sign-up page looks like. Once you're into the registry, if you look at that red oval, you can see there that there's the home page, then there's a page which shows all the studies, which is, this is the page you can see, and you can see I'm on the, you can see the ASOS speeds study information down at the bottom. Then you can see there's a facilities page, which shows all the facility data that we have, so that you don't have to re-enter it every time we do a study. And if a certain study requires a new little bit of information, that gets added to the facility data set. So we've got an ongoing data set which is updated and appropriate, and it helps us understand the background for each study. And then there's a tab which has got all the members of the AppOrg group. If you clicked on the ASOS speed study, for example, a new page will come up, and this is the ASOS speeds page. And here's one can find all the documents, for example, for the protocol, the case report forms, etc., that are needed for understanding the study, for doing ethics and regulatory approvals, who's participating, what hospitals have you know, expressed interest to participate, and what universities. So all the information is there for the researchers. There are a lot of other freely available resources for ethics or ethical research. And I think in time, I would like to see these also populated on the Perioptive Network database, links to all these resources. But I've put together a few which I think are really good. So there's a global health network where most of the clinician researchers in Africa did their GCP training for SOS2 through that. It's an internationally accepted GCP course, and it's free. It's very good. And then if you're trying to set up your own research projects, there's excellent protocol templates and research training in the EDCTP website. And again, it's all free. And then finally, ultimately, we do need to know where all the ethics review boards are in Africa, and who the contact people are. I think that is key if we want to do big research and continue to do that in Africa. There is a project known as the MARC project, which is trying to map the African review boards, ethics review boards in Africa. It's driven predominantly by the infectious diseases groups. It's not complete, but I think these are probably a project that we should all be looking at, is ensuring that we know all our ethics review boards and how to contact them and how to communicate with them. So, in summary, I think, we're doing research as under-resourced clinicians in an under-resourced environment. On the whole, I think the ethics structures in which we work are not well understood, and there are numerous regulatory and ethical requirements. And to be honest, I think a lot of them, there's redundancy as a result, and that needs to be addressed. I think there is extreme value in face-to-face meeting with ethics review boards or the ethics chair, and I would really encourage this, and I'm happy anytime to speak to an ethics review board. I think there are a number of solutions to empower clinical researchers in Africa. There are a lot of very good freely available resources, and I do think the African Perioptive Network database also provides tremendous support for clinician researchers. So this is my last slide. I got two things I think we really need to discuss honestly and often across the network. And the first is, would people support the development of a regional ethics review board? And for big collaborative projects where in a region, certain countries get together and say, yes, I'm happy if this ethics ethical board member is part of this regional board, and if the regional board approves a project which has representation from different countries, that approval will hold in the different countries. I think, if we want to improve outcomes in Africa, and we want to do it at scale, and we want to do it timelessly, we really need to streamline the process. So that the first thing is, I think we need to honestly look at regional ethics review boards. The second thing is, would countries or hospitals consider reciprocity from specific ethics review boards? So are there ethics review boards in Africa that people will consider that their process and practice is of such a high standard that if a project is reviewed and accepted by that review board, other sites will accept that review as acceptable and accept their ethical decision. Thank you.
Bruce. I'd like to apologize to the organizers. I think we're running quite a bit over time with this first talk, but I think if we can aim then to spend another 5 minutes on the topic, and then decrease the break time. I hope that would be acceptable. So Bruce, just from my side, there's currently no questions in the chat, and I hope that people will post their questions there, so it would be easier to get the responses from you. I just have a couple of questions, and maybe I would like your view on this. So the first thing is the data that you showed obviously is from different sites. So it's not categorized per country. So, and I know it's unpublished. So if one shares that type of data with national leaders, and discuss the solutions or possible solutions on a national level for these queries, do you think that's going to make a difference? Also, if you categorize the data according to country origin, don't you think that there is possibly, empowerment just in improving research capacity by empowering national leads with this knowledge, so that they can then at a national level, try and find solutions for this, and also try and find answers to the two questions that you posed at the end. That's the first thing that I just want to ask you. And then I've got just, short other questions. Maybe I would like, it's interesting to, what we've seen is between different IRBs, the issue about waiving consent for an observational trial. I think that's also something that was a topic of conversation during ASOS. So I wonder if you can comment maybe on that. And yeah, I think, if also the differences between the regulatory requirements and the ethics requirements for local sites. That was, in South Africa, where I was the national lead, one of our biggest problems, because between the different regional institutions or provinces, it was difficult to understand what the actual requirements were for regulatory approval. And is there something that you can share with regards to regulatory or government approval in comparison with, or in contrast to the ethics approvals that gave you insight in these studies?
So I think the first thing, your point about the national leaders is very important. And I suppose the first question I posed is about, can we get a regional ethical process going? But your point is well made. I mean, the first thing we actually should be trying to do is, can we get a national approval that the whole country would accept? As soon as you go out of a country into a region, it's a lot more complicated. But maybe the first step should be, in countries, can we get a national approval which is accepted? And sharing the data with the national leaders probably would help a lot. The one thing I didn't discuss, but is certainly relevant to the countries, is just like the clinician researchers, which is all of us, are working in a very difficult environment. Similarly, the ethics review boards have the same scenario. They are exactly like us, they're just in a different role. They're under-resourced. Again, they probably fit into that category of less than one provider per 100,000. And now they got to do ethics reviews. and they don't have a lot of support. As we saw, average review board is 4 people, and that's probably 4 people from a whole big region. So extremely difficult as well. So, talking to review boards and meeting them, I think they really appreciate it because it's difficult for them as well. And maybe, yes, we should be in a more collaborative approach, working with national leaders and seeing if we can start to, organize with the ethics review boards for a more maybe consistent way of doing reviewing at a national level to approve projects. Does that sort of answer your first question?
Yes, thanks. Sagomi Mashinwi also then commented here, and she says, isn't it risky to decentralize ethics reviews as you may lose the inputs from local researchers, especially as we aim to increase research capacity?
So, I mean, it's a difficult question to answer. My feeling is, and what we saw from ASOS 2, for example, where we could not achieve ethics approval from 10% of the sites. I think what certainly would have happened would be to strengthen the ethics review boards through bringing more ethics reviewers together. I find as a lot of the sites have very small review boards, and it's very tricky for them to manage some of these projects. I think sometimes they're quite difficult projects and are quite. I'm nervous to use the word ethically challenging. They're not ethically challenging because they're unethical. I think they're ethically challenging because there's so many things to consider, consenting versus non-consenting, what's happening to the control group. So there are lots of issues, and I sometimes feel the ethics review boards do not have enough support. So if we're going to increase research capacity, and I agree that's what we have to do at all the sites, I actually think bringing more ethics experts together, in other words, as having them, like at a national level, maybe 5 ethics experts will probably be good for the education and knowledge of the group, as opposed to keeping the small sites.
Oh, there's another question here. I just want a quick comment. I think the reciprocity process, or how the decision is made to accept reciprocity from a trusted organization, is maybe something in itself would increase research capacity. I don't think reciprocity should be granted in a blanket fashion, and just, I think every single study that reciprocity is requested from should still be reviewed. It's just that if there is an understanding already in place, it will make it easier for the local ethics board to understand the study and to have contacts to discuss it with at the reciprocal site. Maybe that would both increase capacity and knowledge sharing, and decrease the onerous task of the local board.
I think, sorry, I know we're very late on time, but I think this is an extremely important discussion, particularly in light of what Salome said and what you've just said, Ahela. And it was something that I hadn't really thought about. But, if there are ethics review boards which are considered standard setters on the continent, and there is this consideration that maybe some of them could be used for reciprocal approval, and we want to educate and increase capacity, maybe then what we should be looking at is the sites who are considering or reciprocity if those review boards would accept a member onto the board as not a member who interacts, because that would obviously be very difficult to navigate, but as an observer.
Or an ex officio member, yes.
Yeah, and who's involved in that project, can watch the ethic review process at the reciprocal site and how they deal with all the issues. And maybe that way we can start to develop or increase capacity.
Just a last comment here in the chat box. To get ethical clearance for clinical trial experimental research is very challenging, even in most of African countries. No IRB board, and it makes the process very difficult. And what would be the solution for it in the future? Could the Apple try to develop ethical guidelines and get approval from all volunteered and registered countries' authorized body? I think it's important now that we give our other speakers a chance and try to come back to this issue if we have time at the end. Are you happy with that? I would just like to then introduce our next speaker. It's Bezai, who is an anesthesia lecturer and researcher in Deborah Beran University in Ethiopia, and she studied at Jimma University, postgraduately at Addis Ababa University, and she works as a clinician in Deborah Beran Comprehensive Specialized Hospital. She's passionate about surgical and anesthesia research and training, and she will be speaking to us about perioperative capacity in East Africa. And I just want to apologize. Please don't feel that we need to cut down on the time spent on the next lectures. Thank you.
Okay. Thank you. As I have been introduced, I'm Bezai from Deborah Beran University, Ethiopia. So today I'm going to just speak about one research, which is on perioperative care capacity in East Africa, the results of Ethiopian National Cross-Sectional Study. So going straight forward to the outlines, there will be the introduction of the study and the objective, methods, results, and conclusions will be reviewed. So as an introduction, as most of us would know, perioperative care is not only the intraoperative events in the OR, in the surgery, but it extends from the preoperative evaluation and optimization preparation of the patients, in the intraoperative events, the anesthesia and surgical care, and the postoperative strategies to just optimize and rehabilitate our patients. So if this perioperative care extends this much, it wouldn't be considered as a role of a single specialty. So it involves so many specialties in it, like clinicians, which might be anesthetists, nurses, surgeons, obstetricians, and other scientists like researchers, and leaders and other stakeholders would also have to involve and to collaborate as a joint single force, so that to produce a very safe perioperative care. So in recent years, the provision of safe surgery has gained considerable focus, especially in these 2-3 decades. But despite this increased awareness and very good emphasis given to this perioperative care, there are confounded by it's confounded by a scarcity of perioperative data. But there are coming to the data. There are about estimated 5 billion people which lack access to surgical care whenever they need it, especially in low and middle income countries. And perioperative mortality is also high in low and middle income countries. In surgical patients in Africa are at a very greater increase risk, and anesthesia-related mortality in sub-Saharan African countries is also a higher concern than in high-income countries, which is outlined by African surgical outcome studies. So this study is about East African outcomes, especially Ethiopian outcome. East Africa is a region in which is involved in the sub-Saharan Africa, containing about 9 countries, most of which have made a very significant progress towards sustainable development. In this East Africa, Ethiopia has the largest population. As Ethiopia has the second largest population in Africa, it has the largest population in East Africa, which this country also made an effort to improve healthcare capacity within this last 2 decades, within this about 25 years. From these efforts, we could see that there has been an increase in surgical facilities from about 108 in 2013 to 289 in 2019. And also in 2019, the number of surgeries per 100,000 people was recorded to be 465 in Ethiopia, which has increased by over 10-fold from that of 212, and greater than the rate of the neighboring country, Uganda, which is recorded in 2019, which is 144.5 surgeries per 100,000 population. And also the maternal death rate in Ethiopia was decreased by more than half since 2000, since the recent 2 decades. But despite this expansion of the surgical service, there is an ongoing and widespread resource deficits or limitations all over the facilities in this country. So coming to the objectives, the aim of this study is to provide an updated overview of preoperative facilities status in Ethiopia, which certainly facilitates the identification of a future focus area, which could help us to just have an overview where should we focus on this perioperative care. So as a methodology, this study is an online national cross-sectional study, and it was conducted from September to November 2020. And the survey tool was developed from the existing tools, incorporating the element of this existing 3 tools, which includes the Safe Surgery Hospital Assessment Tool, the World Federation of Society of Anesthesiologists Anesthesia Facility Assessment Tool, and the Lancet Commission on Global Surgery Surgical Assessment Tool. These tools, if you have seen them, they are similar, except the differences of their specialty. So after just combining these tools, we have a final tool which have a final quantitative survey, including about 77 checkbox questions, avoiding an open-ended responses for just clarity and days of completion. So after the survey questions have driven this, we have grouped into teams, we had about 4 teams, the infrastructure team, human resource team, service delivery team, and the availability of medication, equipments, and guidelines team were grouped. Then after an ethical approval was obtained from the Brabham University Review on July 21, 2020. And And this online survey link was sent via email or Telegram to a network for perioperative care collaborators at each site. All collaborators were perioperative practitioners, anesthetists, surgeons, obstetricians, nurses were our data collectors. And after the data was obtained, the survey data was analyzed descriptively using Microsoft Excel to give these results. So this is a distribution of surgical facilities and responding sites. So response were received from surgical facilities within all the 10 administrative regions and two chartered cities in Ethiopia. So our respondent sites was more or less representatives of all regions. So we had a total of 81 facilities from 289 hospitals which completed the survey. So as I was mentioning earlier, there was themes in our questionnaire. So the first one was an infrastructure theme, and so under this an infrastructure theme, we could see number of beds. For example, there are about 4,110 beds, a total of 4,110 beds, which most of these beds goes to the referral level hospitals, about 1,512 beds, which is about 61.1% of the total beds are found in referral level facilities, and about 254 or 10.3% of these beds are found in primary level hospitals. And OR tables, there are about 257 OR tables, which again, the maximum or the highest number of these OR tables goes to the referral level hospitals. About 152 of these beds are found in the referral level hospitals, where only 34 OR tables are found in primary level facilities. So anesthetic preoperative clinic are found in 30 of the facilities from the 81 responding facilities. PACU, there are about 68 facilities having the PACU. 39 facilities has an ICU. And all 81 responding institutions or facilities had an oxygen cylinder in OR. Functioning anesthesia machine in each OR, 74 of our respondents had a functioning anesthesia machine in OR. The rest 7 might have a functioning anesthesia machine in the facility, but they did not have a functioning anesthesia machine in each OR. Piped oxygen, none of our respondent facilities had piped oxygen. And a backup generator, about 7 does not have a backup generator standing up. And so going to the service delivery and workforce team, facilities reported performing a mean of 6.9 surgeries in a day, which ranges about 1 to 37 surgeries per day. And talking to about the workforce, about 23 facilities had no specialty surgical force. About 25 of them had no specialist obstetric workforces, and only 30 facilities reported having subspecialist surgical force, which most of the 30 subspecialties are concentrated in the center of the country. In the majority of the facilities, about 63 or 77.8% of the facilities did not have a physician anesthesiologist. So most of the care in this country is given, most of the pre-operative care is given by non-physician anesthesia providers and the integrated emergency surgical officers, usually especially in primary and general level hospitals. And as we have seen before, there are about 68 facilities which reported about having PACU. So from these 68 facilities having a PACU, about 21 had trained PACU nurses, and the 3 of them had not even delegated PACU nursing staff, which is responsible for the PACU. And seeing the nurse ratio to the patients in the PACU, about 22 of this PACU from the total 68 facilities having PACU have a nurse-patient ratio of 1:2. In the rest of the hospitals, one nurse would oversee all the patients in the PACU. And only 5 of these facilities having the PACU had an assigned anesthesia provider responsible for the PACU. And so coming to the equipment and drug availability, the availability of internationally recommended monitoring devices like pulse oximeter, echocardiogram, and non-invasive blood pressure monitorings were they were found in about 68 of the facilities, which is 83.9%, especially pulse oximeter was found in most of the responding hospitals. So for this, I guess we have to thank the oximetry providing projects, which was done in these 2 decades, the recent 2 past decades. And capnography is available in about 27 of the facilities from the 81 institutions. This capnography is a very vital, I guess, monitoring device, especially for perioperative care, as it could tell us much about the ventilation of the patient, but it usually is not available in our facilities. It kind of is considered as a luxury equipment. And a section was available in all of our, the responding institutions, but it usually is shared between the anesthesia and surgeons in about 37 facilities, and sometimes it even is shared between the OR and the PACU. And availability of airway equipments. So as you can see on the figure, the light gray is indicating the availability of pediatric airway equipment, and the dark gray bar is indicating the availability of the adult airway equipment. So as you could see, the chart or the graph, the availability of pediatric airway equipments is limited more than adult airway equipment availability. So as it's known, Africa and East Africa, of course, is a home of pediatric age grouped populations. So having a less amount of pediatric airway equipments would also contribute for a higher anesthesia-related pediatric mortality and morbidity of these pediatric patients. And coming to the each airway equipment, so the face mask and breathing circuits, the adult ones are found in all of the responding institutions, but the laryngeal mask airway, even the adult ones, most of our facilities lack this laryngeal mask airway, which is a very important instrument, especially for managing difficult airway and complicated or failed intubations. So this equipment is scarce in most of the facilities, the responding facilities. And availability of medications in operating rooms. And again, as we all could see on the table, the availability of ketamine and thiopentone from induction agents, succinylcholine and beclonium from muscle relaxants, halothane from volatile anesthetic agents, petidine from opioids, and adrenaline and atropine from emergency medications are much more good when we see from the numbers. But the availability of the recently specially recommended drugs like propofol from the induction agents, rocuronium from muscle relaxants, sevoflurane and isoflurane from volatile anesthetic agents, and the short-acting opioids like fentanyl and alfentanil, and ephedrine and phenylephrine from emergency medications. They are, as you can see, scarce. There is a very less availability in this drug. So this would make the anesthesia provider, especially, or the anesthesiologist, not to make patient condition center decisions concerning the drugs. So this will also contribute much on increased mortality and morbidity of perioperative patients. So, and availability of guidelines. The use of WHO surgical safety checklist was reported in about 70 facilities. About 86.4 of them have used WHO surgical safety checklists. Again, we have, I think, to thank the Ministry of Health for this, for just enforcing the use of WHO surgical safety checklist, especially within the last 10-15 years, I guess. And an operating room logbook was kept in about 75 of the facilities, and perioperative morbidity and mortality reviews was done in 55 or in 67.9% of the responding facilities. And guidelines like patient transfer and handover guidelines, acute care guidelines, postoperative nausea vomiting management guidelines, acute pain assessment, postoperative pain management, and PACU discharge criteria guidelines availability is very limited, as you can see on the numbers. So just to conclude, despite the expansion of surgical accesses, there is an ongoing and widespread resource deficits if not all, in most of our facilities, and the expansion of surgical capacity should be accompanied by similar expansion in the provision of adequately equipped and staffed post-anesthetic care units and focus on postoperative care. So especially when we are expanding the surgical capacity or the surgical access, we at least have to expand a very crucial resources, equipments for those facilities we are building. Unless we are having a good resource facilities, these facilities will end up to have to increase the mortality and morbidity rates of postoperative, perioperative care. And especially here in Ethiopia, the postoperative care is usually neglected. So we all should have a focus on postoperative care. And the Ministry of Health's coordination of improvement activities with local and international partners is very vital in achieving this. And so I would like to conclude by saying everyone deserves an affordable, timely, and safe perioperative care whenever it is needed. Thank you.
Thank you very much, Bezai. That was extremely interesting, and I have to congratulate you on this very important work that you've been doing. Especially, I personally think the response rate that you had is great, considering that your participants were all perioperative clinicians. I think locally here in South Africa, we sometimes find that the clinicians don't have the buy-in to do to participate in these type of surveys, and they rely on hospital administrators to provide the data. So it's really an immense work that you and the participants have done. Congratulations. I would just like to then, so lots of congratulating messages in the chat box. No questions at this stage, so I think we'll move on. I would like to then introduce Dr. Luigi Pisani. He is an Italian intensivist anesthesiologist working in ICU in Italy. But he's also project coordinator for the Critical Care Africa Asia Network with the Maidol Oxford Research Unit, or MORU. And he works on ICU registries and does registry-based research in more than 10 countries. He's done his PhD at Amsterdam on mechanical ventilation monitoring in low-resource settings, focused on mechanical ventilation observational studies in Asia, and lung ultrasound applications in the critically ill patients in low and middle income countries. He's also responsible for the critical care research for the NGO Doctors with Africa, or CUAMN. He will be speaking about Critical Care Africa, the results, challenges and opportunities for linking and building critical care capacity in Africa. We look forward to your talk, Luigi. Thank you.
Thank you, Haile. Thank you very much. For the kind introduction, and to Fitsum, Dr. Manbeu for the invitation. I speak on behalf of the network, and also Rashan Anifa, Habibin, and all the team that is doing this fantastic work. We do, as disclosures, we do receive funding from UKRI for the African network work, and from the Wellcome Trust for the Asian work, and also for the extension I will mention. My plan for today is to give a little background on critical care in LMICs and ICU registries, a little bit on the network of ICUs that is evolving, data management issues, some practical examples on how, what is the value of ICU registries in our practical lives, challenges, and some conclusions. Little bit of background. You all know that ICU care is expanding very quickly in low and middle income countries. There are gaps, of course, in quality of care, in outcomes. We heard yesterday, and we know that the ACEs and the ACUS studies did shed a light on many disease and on COVID ARDS, of course, in Africa, but we still need a lot to do on data, on capacity, on case mix, on outcomes. There are so many geoeconomic variations. Things are not always as easy as they look. For example, recently we finished a geoeconomic analysis just out a few days ago on mechanical ventilation in non-ARDS patients across many countries around the world. And as you can see, the outcomes are very diverse across high-income countries, upper middle-income countries, and lower middle-income countries. But for example, we could not find any difference in the practice of ventilation. So these processes are complex, and they need a lot of data and a lot of networking. And is there a role for ICU quality databases or ICU registries? There is several names to this. What are these registries? Let's define a little bit. They are repositories of routinely collected healthcare information. Their aim is very clear: to use data to improve safety and quality of patient care. They do provide indicators on structure, on how care is conducted, so processes, and what is achieved. And they do rely on audit and feedback cycle, on which there is a lot of research done, and we know it's effective, and we also know that it's cost effective. Can registries help the first step towards improvement? Well, we think they can through providing data on service evaluation, outcomes, resources allocation, and especially what you have mentioned a lot during yesterday's talks and discussions, through the empowerment and enabling of context-specific clinical research, but also benchmarking at several levels and through the evaluation of the quality of care and then steps to improve it. This is a little bit the structure we use in our network. There is a core data, as you can see in the blue boxes, very simple data on admission assessment and discharge. And then based on your needs, you can add daily data, you can add COVID data, or you can add discharge or long-term outcomes data. It's really context specific. The network started in Asia many years ago. At the time was enthusiastically and unfunded work. It started in Sri Lanka, and the ICU registry then spread to 9 countries in Asia. 40 units in 2020, more than 150 now. It's really a learning by doing model. The principles are quite clear. We have several work packages on registry implementation, quality improvement initiatives, and clinical trials. Just a couple of words on how the data flows. So sites will participate data into national registries. For example, this is the Indian Registry of Intensive Care. There is centralized curation of this data to assure some quality processes. And then the data is fed back to the centers and to third parties. It's very important, and you all mentioned these in your talks, that we have clear principles of data management and data sharing. What are the principles in our network is, of course, international standards, a lot of work on this. The data ownership, that is always.
We did recently do a performance evaluation of the registry infrastructure. I mean, it's so important for you as investigators to know, is the data I'm collecting, is the infrastructure of quality? And we are happy to know that we are in line with many other registries worldwide. So it is possible to collect quality data in low and middle income countries. And we are very happy on that. And this data can then be used in several ways. For example, for observational studies like this one led by Dr. Bharath Kumar in India, analyzing more than 80,000 episodes and coming up validating a severity score specific for low and middle income countries ICUs. But also in the registry, we can enable large trials. You know these trials, you know the REMAP CAP, the recovery study, and we are very happy that now more than 30 centers in the network in Asia are participating, more than 1,000 patients recruited, and several countries in Africa are now undergoing the ethical requirements to participate in REMAP CAP, for example. And coming to Critical Care Africa, well, it is a sister network. It was born just a year ago, and we started with UKRI finding. It's really a south-to-south collaboration, learning from the Asian experience and focused on local stakeholders from several countries. There is Tim Baker in Tanzania, John Amwasi in Ghana, David Thompson in South Africa, and many others that are really building up national networks. In Ethiopia, we are very happy to collaborate with the perioperative network that organized this fantastic meeting. There is also 2 ICUs that started the registry in St. Paul and Abbott, guided by Dr. Manbeu, and also 1 NICU in Waliso Hospital. And what are the principles? They are quite similar to the Asian network: local data ownership, a common data model to then be able to share and compare this data to other registries, not only inside our own network, but compare it with other networks around the world, also in high-income countries. We had 3 activities started last year in end of 2020, and it's registry implementation, it's identification of research priorities, of your research priorities in your sites, and those amenable of quality improvement initiatives, and of course, clinical trials. And interestingly, we are also going beyond ICUs. So, you know, in Africa, the severe patients, Tim said yesterday in his very nice presentation, the severe patient is everywhere. And so we do have obstetric, pediatric, and perioperative focuses. But the topic, the title of my talk was really how to link and build critical care in Africa. And I think here we do have some insight now on how to learn from the Asian experience and from the national registries coming up now in Africa. The message is really, there is now possibilities. We are privileged also to have funding, I must say, and this is a great privilege. So please do reach out if you are interested in joining with your ICU, the Ethiopian team of the Critical Care Africa Asia network. And are we on the right track in terms of building a capacity? I must be sincere, I didn't know this paper from Catherine Chu that Catherine Chu showed yesterday during her talk. And I was like, are we on the right track according to this principle? And I'm happy I could tick almost all of these principles for a sustainable critical care capacity building. So we do have a focus on capacity building. We do have PhD tracks coming up. There are now 5 across Asia and Africa. Local co-PIs are in every country on all the studies and work that we do. It's really building a supportive environment. I think who used this word yesterday was Dr. Alengta. And I think we are really on this track as a network. This takes time. This takes time. And we heard that from Dr. Chu yesterday, but we are happy to spend this time if we are aligned with the principles showed here. And in what practical way we do this? Also through shared research questions, just like in the APERG, you had a shared question that drove your trials. For example, just a few days ago, we had our first investigator meeting for a study looking at direct and indirect patient expenditure and out-of-pocket costs for patients that I think Dr. Munir said that it's a very important priority for the ministry, but also for many of you stakeholders. This was something mentioned many times. And please do come out if any of you want to be in the steering group of this study that we are just writing the protocol at the moment. And it will be a shared study across Asian, across African, and maybe also South American ICUs. Another example of how to work together is on a Delphi large study on ICU indicators specific for low and middle income countries. The work is driven by Brinda Pari from India, but there is also Ethiopian investigators and many others on a set of indicators that is fit for our ICUs in Africa and Asia, and this publication will soon come out. But going more practical, we have this, I mean, registries and networks are a toolkit, and how can we use this toolkit? Sometimes we don't use it, and we might just not use, you know, the data we collect. But how can we use this toolkit in our daily lives? Of course, the perioperative network in Ethiopia has already shown very important work in national level. We have examples in Uganda, in Kenya, that I will mention. Studies running across countries, as I mentioned, but also very important at site level. A lot of my week is really passed through calls with sites at trying to disentangle what are the research priorities for sites. Is it severe malaria? Is it something else? And use the data to work on those research priorities. I think colleagues will discuss the Ethiopian very important experience on which we collaborate. But I would like to give a few more examples on how this network can help you in your daily work. For example, in Freetown, Sierra Leone, we have an obstetric focus in an obstetric high dependency unit. And we built on early work, looking at case mix in this HDU, and the treating team decided to focus on only one thing for a few months. So the patient accessing with sickle cell disease. So they implemented the registry. This is a dashboard that you can see from the registry, more than 500 patients recruited in 15 months. And what we found, for example, in this small group of patients with sickle cell disease, is that they have very similar severity of illness at admission as compared to other patients, but they have much, much worse outcomes. And so QI initiatives are being born, for example, in the blood bank, on the transfusion pipeline, to try and improve these. And this is an example. Another example are embedded RCTs. In Uganda, for example, the ARISE trial led by Arthur Quizera and coordinated by Daphne. So many sites, they are using the platform to enable this large African-based study on high-flow nasal oxygen in acute respiratory failure. And what can the network do for you, for example? Not only the digital platform, okay, we can use the platform and have the study forms and collect the data, but also project management support, data management support. And we are very happy to know that recruitment is really starting as we speak. A third example is, when something comes up to a national registry. It's very exciting when it comes up to a national group. So for example, in Kenya, the team has done a fantastic job in recruiting patients, more than 2,000 patients now under analysis. And we can now participate with some data to the evidence already raised by ACUS, for example. And for example, what we know now is that there is 1/5 of patients under mechanical ventilation in this mixed cohort of patients, not only COVID. We can say something on hemodynamic support, on outcomes, both in ICUs and HDUs, and of course in COVID versus non-COVID patients. And also here, this is the national dashboard. You can see we started very humble, and then sites will come up and the number of patients will increase. Then there is some plateau, and really you need daily work. We meet every week to try and push the work forward, and it's very exciting. And there is a rising interest. Dr. Wambui and colleagues just are collecting data now at the national level. And as you can see, Kenya has a very diverse, as most African countries, status of ICUs, and there is public, there is private, and private not-for-profit. And most people were interested in knowing more about registries or in joining their ICU registries. So this is very important data as well. And I would like to thank the national team in Kenya led by Professor Wangari Siika for really the great work that is being done. It's hard work, it needs time, we all know this, and we also learn from failures. But I think it's really important learning here. Another example is a subgroup analysis that might come. So you mentioned yesterday, Bruce, and others, that perioperative outcomes of children are important, but also ICU outcomes of children are important. And we realize in Kenya, there are so many children admitted to our ICUs. What are the outcomes? What are the resources they use? And are different methods needed? And Dr. Wambui is now analyzing this data. And final example, well, we need to get out of ICUs in Africa, of course. The severe children, the severe patient is also in the wards. If you have a pediatric ward with 10-15% mortality, isn't that an ICU? We may say. And so we are trying to experiment the use of the registry in pediatric wards, for example. And we are collaborating with one of the most ancient NGOs present in Africa. So Doctors with Africa, that's an Italian born, but for example, it's present in Ethiopia, it's from 1980. So a large experience there in district hospitals and a low profile, hard work. And we will try and disentangle the severe patient. And Wolisio in Ethiopia, for example, is participating into this work. So really there are many opportunities to join, not only through ICUs. And so if you know people that are interested in this kind of work, please do reach out. And last minute on challenges, well, I'm really always afraid when I see these big lists of challenges. We all know them. Implementation is hard at different level, but overarching message is practicalities can be solved. And every day we are learning how to solve better. And as Bruce mentioned, ethical practicalities or implementation practicalities, we as a network, we can really help there. And registry implementation is really just the first step. And then we need an intention to use the data to drive things forward. And as someone said to me once, well, a network without the work is just an empty net. So it's really then daily work to use this data. We recently did an analysis also led by Vrinda on facilitators and barriers. And it's interesting then to see what these are in detail. And you can see that electronic data collection and participation in networks are considered facilitators, but we also have barriers like fear for publicity, fear for benchmarking that we do have to face, to discuss, and to solve. And concluding, registries and platform and networks, they are a tool. They are just a tool that then they're open for use in our ICUs, and let's use them. The community of practice that is born is the real driver, is the real gold. And please do reach out if you want to start the registry work in your ICU. You can take different angles. There is no parachuted work. Please reach out to me or to Dr. Sultan or to Fitsum. And we are really open to new centers, and there is also funding to help this. And I really want to acknowledge the team in the Critical Care Africa site leads and national leads to push forward this work. Thank you very much.
Incredible work done by the group. I just have a quick question. We are going to break for 10 minutes, so we'll start the next session 5 minutes late according to my calculations. There are no questions in the chat box at this stage. I just want to ask you, in general, percentage-wise, what do you think data capturing, how much is done by clinicians, perioperative healthcare workers or critical care healthcare workers, and how much is done by administrative personnel across the network now?
Yeah, that's a very important question. It is diverse. So in Asia, in many countries, it's residents and clinicians collecting the data. In Africa at the moment is funded data collectors collecting the data, and the data collector can have different background. It can be nurses, it can be also non-medical staff. But at the moment, we do realize that the medical staff in the ICU, they do not have time to collect the data, actually. But this is under discussion, of course, and different countries and sites do take different approaches.
I hope it's acceptable. Let's make it 13 minutes and we come back to the next session at 10 past 11 East African time. Thank you very much, everybody. Great session, very enjoyable. Thank you.